Hello to everyone. Our today topic is disease of GIT system, gastrointestinal tract system, and some of these diseases you have already known because it's really popular diseases in our population, and we will discuss gastrointestinal tract diseases today. Before we start talking about diseases, let's review our knowledge about normal anatomy and normal histology of these organs. So you should remember that all gastrointestinal tract consists from 4 layers. It's mucosal layer, submucosal layer, muscular layer, and external layer. And mucosal layer in different parts of different parts of GIT system has different structures, and also external layer has different structures. For example, in the esophagus we may see only adventitia and there is no serous membrane here. In a stomach, small intestine and large intestine we may see adventitia and serous membrane also, but serous membrane is the most important part for these anatomical formations. A few words about mucosal layer. In the esophagus, we may see squamous cell non-keratinous epithelium in normal conditions. In human body, in esophagus, non-keratinous epithelium in the esophagus. And the most important glands localized in the submucosal layer. In the gaster, all important glands will localized in the mucosal layer, and the epithelium is prismatic or cylindrical or glandular epithelium, and it formed some crests and papillaries in the stomach. In small intestine we may see really huge or high epithelium and large crests. In the large intestine we may see short crests. So it's few words about typical anatomical formations. And also, if we talk about GIT system, we should remember about special lymphoid follicles which localized in small intestine, and in the submucosal layer we may see placules of Pierov. Pierov placules is accumulation of lymphatic cells in the intestine, and it's like a very important part of immune system of the small intestine. So and for revising your knowledge, you should remember it from histological department, and you have already discussed it in our previous classes, or not only our previous classes but in your previous courses. So the place of esophagus transformation to stomach, it's really special place in which we may see border between esophagus and stomach, and changing from multi-layer polymorphic non-keratinous epithelium to single layer cylindrical epithelium or glandular epithelium. And in this place there are a lot of pathological processes, and if we will today we will discuss some type of esophagitis and processes of transformation of flat epithelium here, of non-keratinous epithelium here, and sometimes there are a lot of tumor of esophagus will start here, and also it's some special place for development of pathological processes. On this slide you may see the most important parts of this area, and I hope you remember about all these structures, and I hope you remember about all functions of these glands, of these layers, and so on and so on and so on. I should pay your attention only for mucosal layer, because in this area we may see border between multi-layer polymorphic non-keratinous epithelium, and a single layer cylindrical. For pathological anatomy, it's the most important part from here. Histological picture of a stomach. It's a true photo of stomach, and we may see mucosal layer, submucosal layer, muscular layer, and muscle layer of the stomach is really huge, and we couldn't see adventitia and other parts of the stomach here. So macroscopically or anatomically, we may see this area like this. We may see esophagus here and connection of esophagus with stomach. And in this part of our body, we may see very important valve. It's cardiac valve of stomach, and in normal condition, it should protect us against regurgitation of acid to esophagus. But sometimes we can see some problems with this valve, and it will be one reason for development of inflammatory reaction in the esophagus. After this connection, we may see stomach, and stomach has three main parts. It's cardiac part of the stomach, fundal part of the stomach, and pyloric part of the stomach. In the pyloric part, we may see pyloric valve, and after pyloric valve, we may see duodenum. And also in this part of the stomach, we may see pyloric valve. And the pyloric valve should protect gaster against regurgitation of bile and other secretions from duodenum to gaster. But sometimes we may see some problems here, and it will lead to some problems with gastritis, and sometimes it may have really difficult complications. And anatomically, we can see large arc of stomach and small arc of the stomach. The small arc of the stomach is a way for food, and in small arc we may see a lot of inflammatory complications, because food is a factor of aggression in the stomach, and the type of food may make a damage in the stomach and lead to some problems like gastritis or ulceration. Excuse me. So, and first of all, we should discuss esophagitis. Esophagitis is an inflammatory disease of esophagus, which accompanied by inflammation of its mucous membrane. The most common cause is gastroesophageal reflux, which leads to damage of the esophageal mucosa due to exposed acid peptic factor. But not only gastroesophageal reflux may be a reason for development of esophagitis. It also may be associated with some food or some chemical substances which people eat, and which may lead to damage of the esophagus. Sometimes we may tell about some different type of inflammation in the esophagus. It may be superficial, catarrhal, serous, or fibrinous, or suppurative. And also one of the special type of esophagitis is a necrotic type of it. A necrotic type of esophagitis associated with really dangerous substances, chemical substances, and there are a lot of cases of suicide which associated with drinking of some dangerous solutions. For example, vinegar or gasoline and so on. And we may see necrotic esophagitis in these cases. One of the typical complications which is associated with reflux from gaster to esophagus is formation of Barrett's esophagus. Barrett's esophagus is a special type of esophagitis which is associated with changing of keratinous epithelium, non-keratinous epithelium, to glandular one, and it's probably like overgrowing of glands from stomach to esophagus, and it's abnormal conditions because it will lead to formation some pathological manifestation of this process. Microscopically, it looks like really hyperemic areas with ulceration, and sometimes we may see malignization of this part of the stomach, and it will lead to some really difficult complications like formation of malignant tumors. So if after esophagus, we should discuss gastric or stomach, and stomach disease associated with imbalance between defense factors and factors of aggression. So let's review some defense factor of the stomach. I hope you really remember it from physiology department, from pathophysiological department, and you should to know that defense factor are mucose production, bicarbonate production, mucosal blood flow, and prostaglandin, which stimulate all of these factors. Aggressive factors or in the stomach may be associated with Helicobacter pylori, and we will discuss this bacteria today, acid secretion or hypersecretion of acid, pepsinogen secretion, and also we should remember about cigarette smoking and using of corticosteroids and some other types of drugs, which will lead to damage of mucosal layer and may lead to formation of some complications. In stomach, we may see gastritis, peptic ulcers, gastritic cancer, and today we will discuss appendicitis. But it's not in the gastric, as you know, it's just my mistake in the presentation. Gastritis is it's an inflammatory process or inflammatory disease in the stomach mucous membrane. And according to the course, it may be acute and chronic. Etiology of gastritis same for acute and for chronic, and it's associated with some endogenous and exogenous factors. Exogenous factors associated with food, with some physical conditions of food. It may be very cold, very hot, or exogenous factors of damage also may be associated with some really dangerous chemical factors like alcohol, medical drugs, chemical substances, influence of microbacteria, microbes and toxins in the stomach, and it's really popular. And in nowadays, there are something about 60% of population have some problems with stomach, and it mostly associated with exogenous factors. But also we should remember about endogenous factors like autoinfections, autointoxications, neuroendocrinal derangements, chronic cardiovascular collapse, and also allergy. If we talk about auto-infections, it may be associated with disbalance of immune system. Auto-intoxication may be associated with kidney failure, and we will discuss it in topic when we will discuss kidney. Neuroendocrinical derangements associated with really huge production of corticosteroids, and corticosteroids will leads to hypersecretion in the stomach. And also we should remember about stress. Stress is a really important risk factor for all gastritic problems, for all problems with stomach, because of innervation, a very important interesting innervation of the stomach. We should remember about vagus nerve, and vagus will stimulate production of acid, and hyperproduction of acid will lead to some problems like gastritis. In case of cardiac collapse, we on our previous classes have already discussed formation of cardiac insufficiency, and it may be associated with chronic hypoxic condition in all internal organs. So, and like a result of chronic hypoxia, we may see some complication in the stomach, development of gastritis or erosions. Types of acute gastritis. According to morphology, it may be simple or catarrhal, and it characterized by catarrhal inflammation, fibrinose type of gastritis associated with fibrinose type of inflammation, purulent, mostly it will be phlegmonose type of gastritis, and necrotic, one of the dangerous from them. The light one is catarrhal, and mostly it will ends without any outcomes. On this slide we may see just simple or catarrhal inflammation in the glands of stomach. We may see accumulation of catarrhal exudate in the glands and in the surface of stomach, and most of all it will associate it only with dyspepsia and some little pain in the stomach area, and mostly it will end without any complications. It's one of the favorable course of gastritis, of acute gastritis. Mostly it associated with some acute infections, gastrointestinal infections, and most of all it will fix without any complications. Fibrinose type of gastritis associated with development of fibrinose inflammation in the wall of stomach, and we may see some plaques, white plaques in the wall of stomach, and this type of exudate will lead to formation of commissures. Sometimes it may be associated with formation of connective tissue, and also it will lead to some problems with motorical function of the stomach. So it's really difficult type of gastritis. But one of the most unfortunate is necrotic type of gastritis. On this slide we may see surface of stomach after suicide, and patient drink something really dangerous. It may be acids or really strong veneer, and like a result we may see big area of bleeding here, and a real big area of necrosis. So, and how you as you remember from our topic about mixed degeneration, we can see special formation of special pigment here. It will be hematine, which associated with contact of red blood cells with acid in the stomach, and that's why we may see really deep black color in the stomach. Outcomes of acute gastritis may be different, and it associated with type of gastritis. It may be full restoration of mucous membrane in case of catarrhal gastritis, for example. Development of chronic gastritis in case if our treatment not enough, and atrophy of mucous membrane and sclerotic deformation of stomach wall, and it typical for phlegmonose and necrotic type of gastritis. And it's really difficult complication which will be associated with losing of functional activity of stomach, and may be associated with dyspeptic complications for a long time, and also with dysmotorical complication in the gas. And also necrotic type of gastritis may be associated with death of patient, and really difficult way of death because it's really painful. Chronic gastritis. Chronic gastritis we divide into three groups. We are autoimmune gastritis type A, non-immune gastritis type B, reflux gastritis type C. It's according to etiology of a process. Autoimmune gastritis or gastritis type A, it's a really rare condition, and we may see it in only 1% of cases with chronic gastritis. It localized in the fundal part of the stomach, Clinically, we can see decrease of acid secretion, pernicious anemia or B12 insufficiency anemia, and increased risk of gastric carcinoma. And especially morphological manifestation is atrophic type of with gastritis. There are no any crysts on surface of stomach, and it's very important to understand why this type of gastritis called like autoimmune, because of in pathomorphological way of development of this pathological condition, there are special stage of formation of autoimmune antibodies to glands of stomach, and that's why we may see atrophy in it, and also it will be associated with decrease of internal Castle factor, and internal Castle factor will be necessary. It is necessary for metabolism of B12, and that's why we may see anemias in this case. And also autoimmune gastritis is a really difficult condition, because in case of chronic injury of glands, of stomach glands, we may see formation of carcinoma, adenocarcinoma in the stomach. Non-immune gastritis or gastritis type B, it's the most common type of gastritis, and if you have chronic gastritis, most of all it should be B type. Etiology is different. It may be endogenous and exogenous etiology, but this endo and exogenous etiology factor is a only stimulating factor for Helicobacter pylori, because in the beginning of the 21st century, some scientists from USA and Australia got a Nobel Prize for development of real etiological factor of this type of gastritis, and it is Helicobacter pylori. And Helicobacter pylori is the important and one of the most important reason for development of chronic gastritis type B. Second name of this gastritis is Helicobacter pylori associated type of gastritis. Localization of this type is antral part of the stomach. Clinically, we can see excessive secretion of acids. More often, it has superficial derangement. And reflux type of gastritis. Reflux type of gastritis associated with insufficiency of pyloric valve of stomach and regurgitation of bile into the gaster or into the stomach. And we may see damage of nihilist cells from this area. And the bile is really aggressive substance, which may lead to difficult damage, and more often it leads to formation of chronic gastritis, and after it we may see formation of cancer here, and really difficult for treatment and difficult for patient. Morphological type of chronic gastritis. So on previous slides we talked about classification according to etiology. According to morphology there are superficial, atrophic, and some rare forms of gastritis. In rare forms we may see eosinophilic, lymphocytic, hypertrophic gastritis, and so on. On this slide we may see normal mucosa of stomach, and we may see really light cells. All of them are same, they looks like same, and there are not any pathological formation here. On case of superficial gastritis, we may see inflammatory reaction here and accumulation of inflammatory cells in the upper part of the glands. In case of atrophic type of gastritis, we may see decrease of glandular layer, and you may check in normal size. You may see valve of glandular layer here and glandular layer here. It's really decreased and depressed. On this slide, we may see rare form like eosinophilic type of gastritis, and also we may see manifestation of atrophic type of gastritis. You may see there are not any crease on surface of stomach, and in the upper part of the slide we may see normal glandular layer or mucosal layer here, and mucosal layer in the case of atrophic type of gastritis. It is decreased in size, and there are not so many glands here. So, and like an outcome of chronic gastritis, we may see formation of peptic ulcer disease. And peptic ulcer disease is a chronic disease with cyclic course. This disease can have a period of light and period of remission and period of rise of pathological process. Morphological substrate of disease is recurrent chronic ulcer of stomach or duodenum, and you should understand that peptic ulcer may localize not only in stomach but also in duodenum. Peptic ulcer may localize in stomach and duodenum. We have already told about it. More frequent in patients with alcohol cirrhosis, chronic obstructive pneumonia disease, pulmonary disease, chronic renal failure. And all of these conditions associated with a lot of dangerous chemical factors in alcohol here, in hypoxic conditions here, and with accumulation of nitrogen products in case of renal failure. And we will discuss renal diseases in some classes, and we will talk about really deep and difficult renal failures, outcomes of it, and causes like Helicobacter pylori, very important for formation of ulcers. Causes of acute gastritis, like not only infection but it's chemical substances, physical substances, or physical conditions, and so on and so on and so on. And one of the most important reason is or causes is stress. Stress leads to activation of vagus innervation, and stimulation of vagus will lead to increase of acid production in the stomach. That's why we may see really difficult complications which will be associated with gastritis firstly, and like an outcome of hyperproductive gastritis we may see peptic ulcer. Pathogenesis of ulcer disease associated with some nervous factors, and we have already discussed it, a few words about vagus, and I think you can tell about it on exam. And hormonal regulation. Hormonal regulation also associated with hormones of stress. It's glucocorticosteroids, and sometimes it will really difficult complication in case of treatment of some rheumatic diseases, because all of them treats with using of corticosteroids, and we may see really difficult damage in the stomach. And also it may be local factors like disbalance between aggressive and defense factors, and we talked about them in the start of our lecture. Morphogenesis of ulcer disease. For formation ulcer, we can see three stages. It's stage of hemorrhagic erosion. After it, we may see formation of acute ulcer, and after acute ulcer, we may see chronic ulcer. Hemorrhagic erosion. It's a superficial defect of gastric mucosa that doesn't reach the muscle plate and heals without scarring. You may see a lot of hemorrhagic erosion in the stomach, and they may be associated with really different types of pathological processes. For example, it may be associated with increase of acids in the stomach. It may be associated with hypoxic conditions of stomach, and so on and so on and so on. But the most important from morphologic point of view is superficial defect, and it should healing without scarring, and it's healing without scarring only because of it damage only mucous membrane, mucous and submucous membrane of the stomach. Acute ulcer, it's a deep defect of gastromucosa with damage of muscle plate and heal with scarring. And on this slide you may see acute ulcer here and here. And after acute ulcer, we may see chronic ulcer. It will be same formation, but with development of connective tissue in the bottom of it. So scarring is a sign of chronic ulcer. And it's really important to understand the difference between hemorrhagic erosion, acute ulcer, and chronic ulcer. From a morphological point of view, it's really different morphological structures because we can see damage only of mucous and submucous in case of erosion, damage of all layers in case of acute ulcer, and in case of chronic ulcer we may see damage of all layers of the stomach with formation of connective tissue. On this slide we may see histologically structures of ulcer. We may see necrotic fibrinoid debris, acute inflammatory infiltrate, granulation tissue also, and fibrotic scarring base. All of these components here like stages and way are necessary for development of it. Also, it's really important to understand, and I hope you understand it, that formation of connective tissue go through formation of granulation tissue. So that's why we may see granulation tissue in the deep of some acute ulcers in a period of reconvalescence of infection, of disease. And after connective tissue, we may see zone of fibrous scarring and development of connective tissue here. So again, few manifestations with formation of ulcers. You may see ulcer, mostly it will be rounded formation and with solid bottom in case of chronic ulcer, like here. Again, and I hope you understand that the size of ulcer may be different, and it's developed only it's developed only it's associated only with strong strength of aggressive factor. It associated with special chemical substances or activity of mycobacteria and so on. You may see really big chronic ulcer. It's chronic because we may see connective tissue on the bottom. Connective tissue has a white color. That's why I think it's chronic ulcer. And in this part of the stomach, we may see only acute ulcer because we may see a lot of fresh hemorrhage here, and we couldn't find any connective tissue in this part of the stomach. One more photo. And complications. Complications of the ulcers may be divided to some groups, like destructive complications, which are associated with perforation, penetration, and hemorrhage. Hemorrhage is the simple complication which is associated with erosion of vessels in the stomach. It's simple for understanding, but it's really difficult for patient because this bleeding sometimes may lead to death of a patient. Perforation, it's formation of hole in the stomach, which will be associated with abdomen cavity, and this complication will be associated with really uh, dangerous condition for life of patient and characterized by really acute pain in area of gaster of stomach. And penetration. Penetration is formation uh, of special fistula between gaster and some surrounding organs like amentum or pancreas or liver, and so on and so on and so on. All surrounding organs may be penetrated by ulcers, and in case of it we may see damage not only stomach but all these surrounding organs, and penetration really difficult for treatment and really difficult in the clinical picture because it have really life dangerous conditions. Inflammatory complications like reactive gastritis. Also, we may see changes from non-suppurative inflammation to suppurative inflammation and formation of phlegmon. Also, we may see reactive duodenitis and periduodenitis. Stenosis and deformation. Stenosis and deformation associated with development of connective tissue in the bottom of ulcer, and it may lead to some motorical complication, and also it will lead to some dyspeptic complications. And also malignization or formation of cancer. Cancer is a malignant tumor from epithelium, and there are a lot of source for growing tumor in stomach. But we will discuss it a bit later. Appendicitis. It's inflammatory disease of appendix, and it characterized by typical clinical syndromes with pain of the right part of the abdomen, with increase of temperature, and so on and so on and so on. There are a lot of surgical manifestation of appendicitis. There are a lot of something about 120 special reasons or special manifestation of appendicitis, and we will not talk about them today. We will talk about morphological manifestation of it and etiology of appendicitis. Etiology of appendicitis may be associated with auto-infection, derangement of permeability of appendix, neurovascular disorders. And if we talk about autoimmune infection, you should understand that appendix it's a special formation in our gastrointestinal tract, and it's end way of GIT, and that's why we may see blockage of it and development of infection in it, and that's why we may see some type of inflammation and some pathological process and development of appendicitis here. Derangement of permeability of appendix and neurovascular disorders also associated with derangement of nerves and vessels in it. According to morphology, there are acute and chronic type of appendicitis, and acute appendicitis may be simple, superficial, destructive, and the destructive forms may be phlegmonous, apostomatose, phlegmonous ulcerated, primary gangrenose, secondary gangrenose, and also gangrene of appendix. And I hope it's clear for you what does mean phlegmon, apostema, phlegmon ulcerating, and gangrena. I hope you remember all these definitions. Phlegmon is special type of separative inflammation, gangrene is special type of necrosis, and I hope you remember about all of them. On this picture we may see simple appendicitis. It increase in the size, we may see hyperemia, and it's all. And it's characterized by catarrhal inflammation. Phlegmonous appendicitis, increased in the size, has really strange picture, and it's characterized by phlegmon in the wall of it. And histologically, we may see accumulation of a pus in the wall of appendix, and in any way it leads to rupture of it and formation of complications of appendicitis. We will discuss it a bit later. Gangrenous appendicitis. Gangrene, you may see gangrene of appendix, and all gangrene associated with blockage of vascular permeability and blood supply in the organ. In case of appendix, it may be associated with blockage by embols, mostly microbial embols, and also with blockage, with mechanical blockage of arteries. Histologically, we may see area of necrosis here and area of gangrene here. Complications of acute appendicitis may be associated with perforation, peritonitis, outer amputation of appendix, empyema of it, periappendicitis, periphlebitis, and abscesses of liver. Perforation associated with rupture of appendix wall. Peritonitis associated with accumulation of intraappendical infiltrate in the abdominal cavity, and its inflammatory reaction in the abdominal cavity. Outer amputation associated with destructive complication, and that's it may happen only when our organism make a lesions between column and appendix. Empyema of appendix. Empyema of appendix, it's a really strong separative inflammation. Periappendicitis is development of reactive type of inflammatory reaction, and we may see periappendicitis reaction in case of formation of chronic type of appendicitis. Periphlebitis and abscesses of liver. One of the most important of them is abscesses of liver, because it's associated with microbial emboli in the liver and development of abscess. And abscess may be intra-liver and also under it. Anatomical manifestation of chronic appendicitis associated with atrophy and sclerosis of the wall, obliteration of appendix, and formation of edema in it. And also it associated with formation of periappendicular infiltrate in this area. Cancer of gastrointestinal tract. So, in the start of our lecture, we discussed special cells which typical for mucosal layer of different part of the GIT, and I hope you remember tumors. We have already discussed it, and you know about source of growth in any parts of stomach or any parts of GIT system. So in most of GIT system we can see glandular epithelium, and only for revising I show you normal glands, and they are characterized by only one layer of these cells with these glandular cells, and they looks like same. We don't have any difference, and they are typical. In case of dysplasia, we may see coloration or hyperstaining of nucleus and change of morphology of some cells, but it's not really difficult and not really dangerous. This pathological process may lead to full fixing of a protein. Again, normal glands characterized by one layer of glandular cells, and they have same anatomical structures. Histologically looks like beautiful cells. And in case of dysplasia, we couldn't find only one layer, and all of these cells are changed. We all have different size, different staining, and different morphology of nucleus, and so on and so on and so on. I hope you may see dysplasia in these slides. And in case of several dysplasia, we may see really difficult or really a huge difference between all these cells. There are not same cells in this area, absolutely. In squamous epithelium, we may see in normal squamous epithelium, cells grow from down to up, and we transformate from non-keratinous to squamous cells. And in case of dysplasia, in my middle type of it, we couldn't find differentiation of cells here, but cells localized layer by layer, layer by layer. In case of deep dysplasia, we couldn't find any layers of these cells, and they grow like without any structures. They grow in any ways. Carcinoma in situ characterized by changing only in the mucous membrane without invasion under the basal membrane of it. Invasive carcinoma characterized by invasive under basal membrane, like in this card, and invasive carcinoma may be disseminated under basal layer, and it leads to overgrowing of a tumor. Premalignant changes associated with metaplasia and dysplasia, and I hope you remember it from topics about tumor. Cancer of esophagus, localization of this pathological process is middle, and it's a border between middle and lower third of esophagus, and premalignant condition associated with diverticular, achalasia of esophagus, chronic esophagitis, leukoplakia, and dysplasia. We will not discuss these processes today, and if you will have some questions, we will discuss it in our classes. Anatomical type of esophageal cancer associated with formation of diffuse infiltrative type or ring-shaped cancer. It appears as an annular or stenosis of the lumen due to infiltration into the wall of esophagus, polypoid, fungated type, or papillary type of cancer. It looks like cauliflower, like masses protruding into the lumen. And this type of cancer will be associated with blockage of the lumen of esophagus and may lead to some special type of complications. Ulcerating type, it looks like a necrotic ulcer. And one of the difficult for diagnostic is infiltrating type or ring-shaped of cancer, because we will see first manifestation only in case of blockage of esophagus. Polypoid and ulcerating type we will find in first manifestation of it, should find. Histologically type of esophagus cancer associated with carcinoma in situ, and we have already discussed how it looks like squamous cell non-keratinous carcinoma, squamous cell keratinized carcinoma, and adenocarcinoma of esophagus. On this slide, we may see carcinoma in situ, and we may see these atypical cells in this area, and they don't have any structures. It's non-keratinous type of tumor, and you may see typical manifestation of it here. Keratinous type of tumor, and with formation of cancer pyrule in the tissue. And complications associated with formation of tracheoesophageal fistula, and like complication we may see aspiration pneumonia, because we may see going of food into trachea, and it's really will lead to really difficult complication. Abscesses also maybe maldevelopment, abscesses of mediastinum, empyema of mediastinum again, mediastinitis, or it may be reactive mediastinitis or mediastinitis associated with overgrowing of tumor, hemorrhage in case of ulcerative form, and cachexia. Cachexia, we have already discussed it in classes about tumors. It's generalized atrophy, which may be associated with two factors in this case. First factor is blockage of esophagus and depress of nutritional, and also it may be associated with general influence of tumor due to organism. Cancer of stomach. Premalignant condition is adenoma of stomach, is benign tumor of mucous membrane. Chronic atrophic gastritis, and we have already discussed it today, it's gastritis type A, which is associated with autoimmune reaction due to or against glands of stomach. Pertinose anemia, it's B12 insufficiency anemia, and again it's associated with internal factor of Castle. Chronic ulcers associated with chronic damage of epithelium cells, and that's why we may see dysplasia of it and development of malignant tumors. Metaplasia and dysplasia of epithelium is like a common pathological processes. Macroscopically, we can see cancer with exophytic growth, endophytic growth, and mixed one. In exophytic growth, we may see plaque-shaped type of cancer. It looks like plaque, some overgrowth in surface of stomach. Polypoid, it looks like polyp. Polyp, it's some overgrowing of stroma of organ with prismatic epithelium, and in this case we may see polyp in stomach. Fungus, and looks like fungi or mushrooms in the stomach. Ulcerated, in ulcerated type of cancer in stomach may be primary ulcerose, cancer ulcer, and ulcer cancer. Ulcer cancer, it's a malignant complication of ulcer disease. Cancer ulcer, it's a process in first step of which we may see development of fungus or polypoid or plaque-shaped type of cancer, and in case of overgrowing it, we may see some necrotic area in this tumor and formation of cancer ulcer. And primary ulcerose, it's some situation when a tumor looks like ulcer, it's grow like an ulcer. Cancer with endophytic growth may be diffuse and infiltrative ulcereous. On this slide we may see some, probably it's fungus or polypoid type of cancer. On this slide we may see plaque-shaped type of cancer in this area. I hope you see it. It's an endophytic type of cancer, and we may see increased lymphatic nodes in all regions here. Again, we may see cancer here. Histologically, most of all, it will be adenocarcinoma, or adenocarcinoma may be high grade, low grade, and undifferentiated at medium grade, low grade, and undifferentiated. Undifferentiated adenocarcinoma may be medullary, solid, cirrus, and signet ring cell cancer. And I hope you remember this classification from tumoral diseases. You should review lecture about tumors, and I hope it will be more understandable for you. And adenosclerosis, it's a really rare condition, I hope. Adenocarcinoma macroscopically may looks like different condition. It may have a lot of forms, but histologically it looks like that. So we may see atypical cells and all reasons of cellular and tissue atypism here. Metastasis. Metastasis in case of stomach cancer we can see by lymphatic way, hematogenous way, and implantational way of metastasis. Uh, lymphatic lymphatic way of metastasis may be orthograde and retrograde. Orthograde metastatic may be in the lymphatic nodes of Virchow. Retrograde may be in the pararectum space and also in the ovarium. Hematogenous metastasis typical for metastasis of stomach cancer in the liver, and by implantation it's metastasis to pancreas gland. On this slide we may see Virchow metastasis, and metastasis of cancer will be found in these lymphatic nodes. Adenocarcinoma by implantic way to pancreas gland. And it's all for today. I hope everything was clear for you. If you want to ask me, please call me and I will explain you again. Thank you for your attention. Bye.